Hello everyone, I'm Anas Al-Ubaidi, and the title for this lecture or the topic for this session is Integrated Patient Cases, Mental Health Disorders within the chapter of Review of Psychiatry Scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Integrated patient cases involving mental health disorders present unique challenges that require a multidimensional approach to documentation and care coordination. Mental health disorders such as depression and anxiety, bipolar disorder, schizophrenia or schizophrenia, and post traumatic stress disorder, PTSD, do not exist in isolation. Rather, they interact with physical health conditions, social factors, and the patient's functional capabilities. Mastering the integration of mental health information into patient documentation is crucial for ensuring continuity of care, developing effective treatment strategies, and guiding medical decision making. For advanced medical scribes, documenting mental health encounters requires understanding the subtleties of patient-reported symptoms, behavior observed during clinical evaluations, and standardized tools used by clinicians to assess mental health. Beyond simply recording these details, scribes play a key role in creating a comprehensive narrative that reflects the patient's condition, treatment response, and progress over time. This becomes particularly important in integrated care models where mental health services are combined with primary care or specialty services, such as in neurology and endocrinology. Effective documentation also serves a legal and ethical role, safeguarding patient confidentiality while providing a detailed account of care delivery. This ensures compliance with regulatory standards under frameworks like HIPAA while accurately reflecting the patient's mental health status and course of treatment. Key points: comprehensive mental health history, gathering and documenting patient history. Importance of context: mental health histories extend beyond symptoms to include psychosocial factors, life events, substance use, and family background. These components help clinicians understand the root causes and triggers of disorders. Example: a 28-year-old woman reports crying spells and lack of motivation since losing her job 3 months ago. Family history reveals her father experienced clinical depression. Symptom chronology: document the onset, progression, and duration of symptoms to differentiate between acute disorders, for example, adjustment disorders, and chronic conditions, for example, GAD, generalized anxiety disorder, or bipolar disorder. Evaluate for comorbid symptoms such as sleep disturbances or appetite changes that may indicate specific diagnoses. Cultural implications: consider cultural and social attitudes toward mental health and psychotherapy. This can impact a patient's willingness to engage with the treatment. Example: patient hesitant to discuss personal trauma due to cultural stigmatization around mental health. And here is a diagram on understanding mental health history challenges. Assessment tools and their role: standardized and structured assessments, mental health screening tools like the PHQ-9 for depression and GAD-7 for anxiety provide measurable insights into symptom severity. Example: a PHQ-9 score of 18 indicates moderately severe depression, necessitating treatment escalation. And here is a diagram showing the mental health assessment tools and their applications. Mental status exam, MSE. The MSE evaluates mood, thought content, cognition, and affect. It is a core component of mental health evaluations. Example: patient appeared disheveled with a flat affect and incoherent speech requiring immediate stabilization. Specialized skills tools like the GAGE questionnaire, CAGE, for substance misuse, or the CSSRS for suicide risk assessment, highlight critical risks that must be immediately documented and addressed. Tracking diagnoses over time. Scribes should ensure that assessment scores are consistently recorded across visits to provide a comparative view of progress or regression. Example, patient's GAD-7 score reduced from 15 to 9 after CBT, cognitive behavioral therapy implementation. Treatment plans and documentation. Effective recording of multimodal interventions, combined treatment approaches. Treatment for mental health disorders often integrates psychotherapy with pharmacological approaches. Documenting both ensures a complete representation of the care plan. Example, prescribed 100 milligrams sertraline for depression. Patient will attend cognitive behavioral therapy CBT weekly to address behavioral patterns. Patient collaboration, clear documentation of patient goals improves care engagement. Example, patient aims to reduce panic episodes from daily occurrences to one per week over the next 2 months. Monitoring side effects. Psychotropic medications often come with significant side effects. Accurate recording ensures adverse reactions are appropriately managed. Example, patient reports vivid dreams after starting selective serotonin reuptake inhibitor medication, which is example sertraline, for example. Schedule dose adjustment discussed. Confidentiality and ethical responsibilities. Safeguarding sensitive information, compliance with HIPAA. Behavioral health records require heightened privacy measures, differentiating between standard progress notes and protected psychotherapy notes. Example, psychotherapy notes contain client-specific processing insights, access restricted per regulation. Consent for sharing information. Obtain explicit consent prior to disclosing patient information to family members or other care providers. Example, patient signed consent for case discussion with a primary care physician regarding anxiety management. Mandatory reporting document details of crisis situations where mandated reporting applies, such as suicide plans or threats to others. Example, patient expressed intent to self-harm but denied access to means. Follow-up care and longitudinal documentation ensuring continuity of care. Progress notes. Use the SOAP format, subjective, objective assessment, and plan to ensure all notes are structured and detailed. Example, subjective, patient reports improved sleep after stopping alcohol use. Objective, appears alert and focused. Assessment, alcohol-induced insomnia improving. Plan, continue therapy and abstinence monitoring. Collaborative care. Mental health care often involves multiple providers. Scribes must ensure follow-up plans include input from psychiatry, primary care, and specialty services. Example, refer to neurology for coexisting migraines with subsequent feedback incorporated into mental health care plan. Outcome monitoring. Clearly summarize improvements or challenges in progress notes. Example, patient reports 50% reduction in anxiety episodes compared to baseline. Summary tables. We have here table on common mental health symptoms and disorders, table on assessment tools for mental health disorders, table on multimodal treatment plans, table on confidentiality and ethical documentation, table on follow-up and progress report components, and then next we will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. Which of the following tools is most appropriate for assessing the severity of depression in a patient presenting with low mood, fatigue, and loss of appetite? A. GAD-7 GAD, which is not for depression, it's for anxiety. Gauge questionnaire, it's not for depression. B. It's for alcohol or substance use. C. PHQ-9, most likely this one. D. Columbia Suicide Severity Rating Scale. C. SSRS, it's for suicide ideation. So the answer is C, as the PHQ-9 is a standardized tool specifically designed to assess depression severity. Question 2. What is the main priority when documenting suicidal ideation during a mental health assessment? A. Recording only passive ideation to avoid alarming the care team. B. Confirming active ideation with a detailed safety plan. C. Minimizing details to protect patient confidentiality. Or D. Focusing only on the patient's willingness to contact support services. It is B. The answer is B, as documenting suicidal ideation requires distinguishing between passive and active thoughts, and ensuring a clear safety plan is included for crisis management. Question 3. Which documentation practice ensures compliance with HIPAA regulations for psychotherapy notes? A. Including therapy session summaries and standard progress notes. B. Separating detailed psychotherapy notes from medical records. C. Omitting patient details completely to avoid confidentiality breaches. Or D. Sharing notes freely between different care teams without consent. The answer is B, as psychotherapy notes are protected under HIPAA and require heightened confidentiality. These notes should be stored separately from the general medical record and only shared with explicit patient consent. Question 4. What is the primary focus of follow-up documentation for a patient with generalized anxiety disorder, GAD-GAD? A. Reassessing physical symptoms unrelated to anxiety. B. Tracking medication adherence and therapy outcomes. C. Documenting family history of anxiety disorders. Or D. Reducing the frequency of follow-up visits to save time. Answer is B. Tracking medication adherence and therapy outcomes, as follow-up documentation for GAD, generalized anxiety disorder, should prioritize tracking therapeutic progress, including symptom changes, adherence to treatment, medications and therapy, and functional improvements. Question 5. When using the GAGE-CAG questionnaire, a positive screening indicates which of the following? A. The patient is at risk for imminent self-harm. B. The patient may have clinically significant substance misuse. C. The patient is displaying symptoms of generalized anxiety. Or D. The patient requires an immediate psychiatric referral. Answer is B, as the GAGE questionnaire screens for substance misuse, specifically alcohol use disorders. A positive result, 2 or more yes responses, highlights potential substance-related concerns that require further assessment and care planning. It does not assess self-harm risk, generalized anxiety, or mandate immediate psychiatric referral unless other risk factors are present. And here we come to the end of this lecture. Thank you very much, and goodbye.